Welcome to the American Amnion Association Podcast, where we dive deep into the world of birth tissue-derived products and their incredible impact on healthcare. We explore innovation, collaboration, and the transformative potential of amniotic membrane therapy, one of the most exciting frontiers in regenerative medicine. I'm your host, Theresa Hong, and today we have a truly special guest, Dr. Michael Johnson. Not only is he a highly respected optometrist, but he's also a visionary in the field. Using amniotic membrane to treat patients with complex ocular conditions, Dr. Johnson has seen firsthand how this groundbreaking therapy is changing lives, offering relief and recovery where traditional treatments fall short. A bit about Dr. Johnson. He's a graduate of the UAB School of Optometry, where he earned the prestigious Kossuth Scholar Award and participated in vision science research. His career has been dedicated to improving eye health, from working with underserved patients to leading clinics across northeastern Alabama. He's also served as chief optometrist for the 908th Medical Reserve Unit at Maxwell Air Force Base, providing care to nearly 1,000 service members and earning the rank of captain in the U.S. Air Force Reserves. Today, Dr. Johnson is making a significant impact in the Glencoe and Gaston, Alabama areas, where he continues to serve patients and advance the field of optometry. He also serves as a KOL for ophthalmologics, a leader in amniotic membrane treatment, as well as our CMO of optometry for the American Amnion Association, where he leads efforts in regulatory compliance, safety, and the clinical integration of amniotic membrane therapies in optometry. I'm also honored to call him a friend. Dr. Johnson's commitment to patient care, his expertise in regenerative medicine, and his passion for innovation make him the perfect guest for today's discussion. We'll explore how amniotic membrane is revolutionizing eye care, the science behind its success, and what the future holds for this cutting-edge treatment. Dr. Johnson, welcome to the show, and I'm thrilled to have you on.
Thank you, Theresa. Thank you. Very, very kind words. I am honored to be on the show, but also very honored to be called a friend. Very much so.
Oh, hey, likewise. Yes, and you've been very, very busy. I've been trying to get you on this podcast for a while now. So you were just moving in a million different directions.
Oh my goodness, but it's everything Amnion. It's been a great 2025 started out with a bang. I mean, I would say my biggest role is teaching some of the optometry students in some of the schools about amnion benefits, where it's derived from, kind of reducing some of those stigmas that are out there, but just getting them comfortable to be able to use it and implement it into their practices. And then, I work with my nursing home groups as well. So it's an amazing thing that the non-eye care related individuals, the listeners out there that are listening, and well, why has this not been introduced into my practice? Well, we are still introducing it into practices as we speak. Doctors are just blown away at the responses. So yeah, it's been a great year. We've been busy. I'm glad I got to be involved. I think the more we can talk about it and the more we can spread the word, it's only going to benefit patients. It's only going to benefit the practices. It's a win-win all the way around. I mean, I know I sound like a sales pitch, but it's just, when you see it, it's just amazing. I just had one of my doctors in Florida that's a nursing home practitioner, and she sent this group message and was like, you guys just won't believe this. This patient had exposure keratitis, which is basically where the eyelids don't close all the way. So an older person that has loose eyelids, or, the grandparent that has that lower lid that rolls out a little bit. And so their eyes are exposed to the world, and it causes a really bad surface issue. And their vision was 2100. They applied a membrane. It immediately went to 2060, right?
Wow.
After one application, and then she went back for the 1 month follow-up and did a second treatment. And this individual's back to 2030, but it had never even been introduced. I mean, it's stories after stories of that, where it's a success story, getting the comfort levels back, getting immediate responses, being able to add this to the already in place therapy. It's just, we've known the technology's been there. It's just getting over the barriers of what is it, where does it come from, how can it help my practice, and allowing the patients to have access of care. I mean, we live in the United States of America, and it's 2025. Everybody should be knowledgeable or know that it's available. That's kind of my mindset,
Yeah. And how were you introduced to it, Dr. Johnson?
So I was introduced to it in nursing home care. I was several years ago. I was a young practicing optometrist, and I was dealing with a patient that had, again, a very severe reduced issue. Vision was reduced. They were in a lot of pain. And in the nursing home setting, you're already making a few, shall we say, compromises where it's not your normal brick and mortar practice. And so you may go to a nursing home as a doctor and visit a patient. You're not going to be able to physically check on them every single day. You might go back in a week, or you might go back for another follow-up visit in 2 weeks or even a month. And you're relying upon the staff to instill the eye drops or continue the care that you are prescribing, the directive, if you will. And most of the times there's staff turnover, there's just communication issues, there's barriers in the way. So I'm not going to imply that there was any wrongdoing, but there's just so much change and ebb and flow and moving parts that I just needed to find and research, and happened to be at a conference and had a booth. And it just goes to show that when these companies like Ophthalmic goes to these conferences, we think, man, are we really helping somebody? Talk in all of these doctors, you're planting these seeds, and then they go back home, they pick up the phone, they call. I order a couple membranes, and I see immediate responses. So yeah, years ago, that's exactly how I was introduced, and um, it was a really cool story how I got involved with Ophthalmics. I was using the Eclipse product, which is the for the listeners out there, it's very similar to almost like a disc. I'm not going to call it a contact lens because it's not a lens. It's more of like almost like a very thin, opaque, semi-transparent disc, right? Like almost like imagine a wax paper disc, if you will, but it's made of amnion. It's about 35, 40 microns thick, and you can use it on either side. And we were using this, and I had this patient that needed a bilateral treatment, and I believe the CEO Chris Solis was just gracious enough to take a phone call, and we had this idea of adding an open viewing port into the membrane. And so they were already in talks with one of the other KOLs, and we all put our heads together. And so you had a company that was listening, and we all had this idea. And so the marriage of how I got involved and then how I came to be with Ophthalmics was plain and simple. The company's powers that be, they were listening, and they were able to say, yeah, we can build this. We're already working on something similar. Let's build this. And so I was like, I love this product. I love the way the company is going to bat for helping us help our patients. So what came to be was what's called the Aurora amniotic membrane, where it's literally looks like a disc. It has an open viewing port about 5 millimeters in size, and the patient can wear it, get the relief from the pain, the irritation, but they can also get the advanced properties of the same amnion, where they can have the antibacterial properties, the anti-inflammatory properties, the anti-angiogenic properties. What does that mean? That means that we are helping resurface that eye real time, immediately, and give the damaged, compromised tissue. That is in our world, that's what we call a keratitis. Any type of inflamed, the first part of that in Latin, kerato, Kera, is cornea. That this means front of the eye. So any keratitis implies that the front of the eye is inflamed or compromised or damaged from an infectious manner, or from a mechanical exposure, or some type of virus, or even from trauma. There's so many different avenues to treat with this. So yeah, you can treat this and get that cornea to be healed real time. And these individuals that need to go pick up their grandkids and drive a car, they won't have a reduced vision. Or let that one individual that still is able to walk around on his own in a nursing home, you don't want him to fall and potentially miss a step and hurt his hip that would lead to other more involved issues with the secondary sequelae of breaking your hip or something like that. And you would never want that. So we have two products of different sizes that can treat pretty much 18, 19 different clinical indications.
Wow.
And usually you can get resolution, or at least some improvement a market improvement within 3 days.
Wow. So the whole nursing home aspect of your practice, how did you come about that? And, you know, why was it kind of a eureka moment with using, amniotic like membranes in these, elderly people? I mean, a lot of them, I mean, I would assume a lot of them are kind of
Sure.
incapacitated and not really
Well,
knowing what's going on, and I'm just wondering, what kind of of conditions are you treating this on, and what's the compliance rate, just because they're, older individuals and
well, that's a loaded question where, people have this stigma of nursing homes and they think of a bedbound individual that has cognitive issues to where they're not going to be communicative, but that's not quite the whole picture. I would say that's maybe 30% of the entire nursing home population, right?
okay.
So most nursing homes have different layers where it's a short term or a long term or some type of skilled nursing facility. And so that's where we are mandated by the states that when that individual goes into a nursing home, and I started years ago when I was in school, we had to do rotations. So every optometry student has to do a rotation through a nursing home. It's just
Oh, okay.
some individuals learn during that time that might not be the modality that's for them. And then some individuals like myself that had both of my grandmothers go into end stage Alzheimer's cognitive units. And I witnessed how they were cared for. One of them had wonderful care. The other one had some rather sporadic, sketchy, scenarios that I just felt like
Sure.
if you're a passionate individual that's a healthcare provider, one, you went into the medical field because you want to help people.
Amen.
There's a subset of providers that are drawn to the notion and the idea that people that are in a nursing home are in the latter chapters of their life. Okay, they are still individuals that nursing home takes on their place of residence. So there are mandates by the state to where they are required to, provide them privacy, provide them their liberties, if you will, right? So if they are diabetic, then they are mandated to have their eye examined. If they have any complaints whatsoever about their eyes are burning, itching, blurry, the facility is mandated to provide a care service for them. So it's not like I'm just willy-nilly walking into a facility saying, hey, do you have 10 people that need to be seen? It's a very structured where I know a month ahead of time this facility has these 15 to 20 people, and I already know if they have complaints, whatnot. But we have equipment in place for the cognitive impaired that we can do a full exam, pretty much like a non-communicative individual that's on the spectrum. We have devices that we can get their prescriptions without them saying a word. We can do retinal photos. We can do evaluations on the front of the eye for the dryness issues, things of that nature. And so most of the time, what we encounter are the individuals that have the neurological issues, the Parkinson's, the exposure issues, the post, um, stroke type individuals where they may not blink as frequently as you normally would, or the brain may not get the message that the eyes are dry and burning, and so they're just exposed and their eyes
Wow.
open. They may have a looser lid droop or facial droop from a stroke or a Bell's palsy where their eyelid is exposed. And then they may be, and in most cases, they're usually on 8, 10, 12 medications that are to keep their heart pumping and to keep them from going into a some type of psychosis because of a cerebrovascular event or because of the cognitive um, situation that they're in. So the medications could cause dryness issues or reduced function of the eye. So we see a litany of findings. I would say out of a 20 patient day, I would say 2 to 4 of them are needing some type of extra step therapy. What do I mean by extra step therapy? We have a very scripted step where we don't just walk in and say, you get a membrane or you get a membrane. It's not like Oprah's Monday show or anything like that. We have to follow what's called the dry eye workshop, that a group of doctors back in 2017, the Tear Film and Ocular Surface Society got together, and it's literally a workshop sheet or a flow plan, if you will, where step one is finding the surface issues, the dryness issues, educate the patient or staff, artificial tears, warm compresses. Step two would be adding some type of omegas, nutritional flaxseed oil, walnuts, omegas, things of that nature. Step three would be after you've introduced a topical medication. So artificial tears are over the counter. Those you can get anywhere, but there are prescription eye drops. A lot of people have been around for years know Restasis. That's been around. Even the actress from Northern Exposure from the 80s and the 90s, she was the main commercial person, right? Then you had
Right.
Zydra. Then you have Sequa. You've got all of those are specifically targeted and FDA approved for dry eye keratitis surface issues. You have Isuvist. It's one of the most recent ones that's FDA approved steroid for dry eyes. That's loteprednol 0.25%. That's low enough that it's not going to be causing any eye pressure issues. For the listeners out there that have been told for 50 years, don't take steroids because you'll get glaucoma. That one's FDA approved. It's safe. You have a newer one that's called Meibo that helps pull the oils out of the eyes. Well, the problem you have is all of those are for different variations of dry eye or surface issues. And what do if you show up to a nursing facility, or let's just say your brick and mortar practice, and you see Mrs. Jane Doe, and you see her back for a 1 month follow-up, and it's still not any better? Then what do? You put the evaluation staining in the eye, and there's still all of these little spot marks of areas of dryness where the eye is exposed and causes these little spots of damage, burning, irritation. Well, do you add punctal plugs to stop the tear drainage? Well, what if they have a tear production problem? That won't help you because you're going to be draining.
Right.
You can't drain a bathtub that has no water in it, right? So,
Right.
but that's where amniotic membranes come into play. Is why are we trying to keep putting, a band-aid on an issue, if you will, what if the bigger issues we need to actually change the surface of the playing field, right?
Yeah.
So the cornea is damaged. And so every time the patient is blinking, the surface is not being rehydrated and properly introduced to tears with the proteins and all these anti-inflammatories and these cytokines to allow the tears to stick together, right? Well, the amniotic membrane, the amnion, if you will, absorbs into that damaged, compromised surface and takes on the new epithelium. So it immediately resurfaces
Wow.
and becomes a healthier new playing field. It's kind of like a farmer that has a crop that has reduced its yield, and they do a soil test. And they find that their soil is not vibrant anymore. It's lacking nitrogen or whatever it is. I'm not a farmer, so I'm just making the assumption. But what do? They replow, they retill, they bring in new soil, or they move and have a newer, healthier bed to work with. That's exactly what amnion does. But instead of it doing it in 2-3 months, you're immediately doing it, right? So if you add that as your step 3, which is the dry eye workshop protocol, and allow that to resurface itself, and then keep them on those drops that you had them on, or go back to the artificial tears, it allows you to basically have a clean slate, if you will. But
So why then, like, why would that be step three? If you could identify, a condition or an issue at the very beginning and say, oh, you know, an
you are
amniotic
correct.
membrane would
You're
would
correct.
would be great on this. I mean, what is that? Is that policy?
Well,
Is that regulation? Is that, what is it? And not to knock, any of the regulation or anything at this point in time, insurance companies, but I'm just, I'm curious, and I'm sure our viewers are curious, to where if it works so well, why wouldn't that be your first kind of go-to treatment?
Well, so there's the answer is you can. Okay, so there are certain cases where if you have an open epithelial defect or a chronic epithelial defect where your eye is in a compromised state and you're in severe pain and the doctor can document that, hey, there is a risk of loss of vision permanently with scarring, or there's a severe pain is imminent and there is a need for immediate treatment. We do not want to wait to get the eye drops to fix it for a month. Yes, there are cases, and the way Ophthalogix built it is we've got this little card that's inserted into the little packet when you buy the membranes. And there are about 16 diagnosis codes. Eye care providers, we refer to those as ICD-10s. And when I talk to these students, I say, you're going to live in the H16s to the H18s. So there's about 14 to 16 very go-to where if you have that and there's risk of that, you can go straight to a membrane. Yes. I would highly recommend the listeners out there know that the majority of the time, most of your providers are going to follow a protocol really to help ensure that your insurance reimburses the coverage for it. So we live in a world where if the need is there, the doctor has to basically have the patient sign what's called an advanced beneficiary notice. That's not just for amnion. That is for every procedure out there, right? You have to sign a form as a patient saying, I acknowledge that I approve this treatment being rendered to me. Here's the risks. I was given all the risks and benefits. And in the event that my insurance doesn't cover it, I will be financially responsible. So that's not for membrane. That's for everything out there, whether it's an elective procedure. And so the reason they do that is because there may be some insurances out there. I'm not going to name names because that's not what this podcast is about. But there are several out there that will send back a letter saying, hey, we need to see your documentation and justification of benefits to substantiate reimbursing this claim. And that's where I document the complaints. I document my findings, any failed attempts, which would have been steps 1, 2, and 3 of the dry eye workshop. So that's usually why it's in place, is so that when it gets to, this is why I did it, here's the photos, and this is the medical justification. Yes. There's been several cases where I felt like the need was justified, and I sent them all of my paperwork, all of my exam findings, and they approve it because they just want to know that I'm not abusing the system and saying,
for sure.
So it goes back to, because it works so well, you could go down a slippery slope where doctors could be like, you get a membrane. Oh, your eyes, your eyes are bothering you today. You get a membrane, and it's not really what it's for. This is for those individuals that have been on eye drops for years, and they are, that's what I tell my patients. When would I use this? Well, if you've got a patient that's using eye drops 4 and 5 times a day, and it's not helping, there's a problem. There needs to be more tests involved. If you've got an individual that's not on teardrops alone, but on some other added therapy, and it's still not giving relief, something's wrong, right? And most of the time, it's a sleeper condition that's called neurotrophic keratitis, where the findings, what I see in clinic doesn't match what the patient is complaining about, right? I can say, well, Miss Jones, it looks really good. Well, it feels terrible. I'm having to use drops every 2 hours. And then we do a very specific sensitivity test where we have this little filament and we run it across the cornea. And if they don't react, and that tells you that area has been so chronically exposed and dry that it's starting to lose its sensitivity, then you have an immediate, okay, we are in go time. We have got to save this corneal tissue, this sensitivity, because I can assure you that the insurance would much rather pay for a membrane 1 or 2 times, because there's There's only one drug on the market that's an eye drop to help save that. It's called Oxervate, and it is extremely expensive. So
Mm-hmm.
they know
Mm-hmm.
that if we're getting to that point, it's all hands on deck, and they will gladly start covering membranes. So yeah, I think that answered your question. Is yes, you can use it in several cases where if the listeners out there that if any of that kind of hit a buzzword and said, well, wait a
Yeah.
minute, that's me. I'm walking around with a bottle of teardrops in my purse all the time, or every time I get in my car, I have to put drops in because the wind is bothering me and nothing is helping. That's their red flag to just have a conversation with their provider and say, hey, have you ever heard of these membranes? And I would be shocked because I know Ophthalmologics is at all of the major conferences. We're doing a really cool thing where we're doing workshops now where we're teaching these doctors. So not just students, but we're also finding that older doctors weren't really exposed. They were in that window where they graduated in the late 90s, early 2000s, and they weren't really privy to being educated on the insertion and applications or the clinical indications. And so that's what we're doing is we're going to them and saying, hey, sign up for this workshop. It's part of your education program. We will teach you. We will teach you the
Yeah.
whole process because I think it's one of those, no one teach one, show one type thing where we're all in it
Sure.
together. So
So okay, so when you do, apply an amniotic membrane, to your patients, what it, do you find then when all other treatment has failed, or in the case that you were just explaining to me, sometimes it's like, oh geez, like we're going to go ahead and we're going to put one in now. What are the results? I mean, is it just a home run every time? Is it, kind of hit or miss? Like what are
right,
the outcomes?
I would say 9 times out of 10, I'm not going to say a home run, but maybe an in the park home run type sensation where it's just they're a little skeptical because they're not sure what you're doing. I mean, most of these individuals are older. Let's just be honest. Most of them are older. Most of them have never even been exposed to wearing a contact lens. And so
Sure.
there's just a range of emotions going on where it's like, oh, I have to wear a bandage contact lens for a couple days. What's that going to feel like? Am I going to feel this membrane on my eye? And so once they get past all of that, where we apply the membrane and then do the bandage contact lens in place, and then they're sitting there for a few moments and they're like, well, I don't feel anything. That's the goal. That's the goal. Most of the time, 9 times out of 10, they are getting immediate relief. And I would say, I don't have a number to it, but most of them are extremely happy from the relief standpoint, from the
Nice.
improved comfort standpoint. Ecstatic might be the right word, where most of these people know that there's a problem and they are ecstatic about the results. Usually three days is usually when I say you're going to be back in my office in about 3 to 4 days. We're going to take this bandage lens off, and by the time they come back, almost all of them are like, man, I feel better. I'm not having that sharp shooting pain. And then there's like, I'm excited to get this bandage lens off to see if it feels the same. And when I take that bandage lens off and they don't feel any pain, usually that's when you see the ecstatic shoulders dropping,
Nice.
like the relief. So yeah, your compromised individuals, it's just amazing. The individuals that are in the nursing homes, they can't really relay like what their feelings are, what their sensations are.
Sure.
But most of the time, I know that we're having a positive result because the family members are almost always present when I'm removing or applying. So in a nursing home setting, you're not really going to use a bandage contact lens because that would run the risk of other complications. But we use
Sure.
what we call we do these kits at Ophthalmologics where the resident would get a pressure patch with an iPad or a foam patch, surgical tape, and we actually put it in place. And so in my clinical settings, I will do the follow-up slash amniotic membrane application. Those are the first patients I see in the morning. I go straight to their bed and I will put the amnion on. I will put the pressure patch in place, tape them up, and I'll go see the rest of my patients, because in about 5 hours, I'll come back through and check on them and take the bandage off. And usually by that time, the family member is in the room because they're like,
Yeah.
what's going on? And
Yeah.
so that's my time to be able to educate them on what we're doing, and they can observe them. And when I see them back for a follow-up visit the next week or the next month, they will say, hey, it looked really good. There was no redness. The haziness of my sister's eye was just so much better. She didn't complain about needing drops. And so usually the family members are asking, when is the next time you can apply another one? So
Wow.
so it's
Wow.
it's it's
And
just, there's so
do
many
they
layers.
understand? I mean, do you educate the family sometimes as far as like, hey, this is amnion, like this is a birth tissue derived product. I mean, this comes from something that, made
Uh,
a baby. I mean, do they
yeah.
grasp that?
So well, we have to. So that is something that we have to do our due diligence and actually let them know and educate them. The packet has this whole informative sheet that gives them the testing, right? So the what we call the ISO standards, right? So any lab slash pharmaceutical or anything of that nature, you have to have all these standards as far as the sterility and how pristine the tissue is. And we can show them and say, now listen, this tissue is bio tissue that was donated and harvested from 100% consensual mothers that did planned cesarean C-sections. And there was no ill will involved. Usually that's the term I use, because everybody has a stigma of, where did you get this from?
Sure.
They think
Right.
it's some
Yeah.
traumatic situation. And when they hear that we go through, when the mother decides to donate, she has to go through a testing sequence for communicable diseases, bloodborne diseases, all of the normal things that go through your head. She has to be cleared from that. But then when the tissue is harvested after a planned cesarean, so that we know that no other bodily fluid slash tissues were
Sure.
cross contaminated, if you will, then that tissue still has to go through another sequence of testing. So for the listeners out there, I cannot find another way of explaining that. It is the most structured donation type sequence. I dealt with the Alabama Eye Bank, where individuals that have passed away donate the corneas for transplants. And they have an individual that comes in and uses a spacer, takes it out, puts it in a little thing. And it
Yeah.
was so rudimentary and simplistic. And then you talk about the sequence of how we know down to what hospitals and where they were derived from. So no, this is a very documented. So your question was, do I educate? I overly educate, because I want them to know that it was from the amnion, which is the innermost lining of the placenta. So it's not the fluid floating around. It's not the chorion. It's the amnion. That's the inner lining facing the fetus. It is not fetal tissue. It is not afterbirth. It is a structured layer that we're targeting. And then I tell them the reason that we use that particular layer is because it is 5 layers of tissue that is I'm not going to say bioidentical, but it is biosimilar, as in the same 5 layers of the front of the eyeball that we're trying to heal. It is unbelievable.
Amazing.
It's the similarities. It takes on the properties of the cornea. It absorbs into place because it's got the basement membrane, the stromal layer, which is the thicker part of the cornea, and it's got the epithelial layer. So it's a match made in heaven for what us eye doctors need. It's and the part that really just blows us our minds as doctors is that the procedure is so simple. The application procedure, literally, you numb the eye, you use these forceps that are holding it in place, and it's bi-directional. So I can apply it to the cornea this way, or I can flip it and apply it this way, up or down. It's omnidirectional, so I can go either way. And maybe 30 seconds. Maybe 30 seconds. The longest time is getting the patient prepped and cleaned up, getting my we call it our utensils. So in the nursing home setting, we get this surgical drape, and most of the time the individuals are lying on their bed. So I just use their
Yeah.
their bed and apply everything and maintain sterility. And then putting the drops in. That takes the longest time. The application itself, I'll be talking to the patients. I'll hold their eyelid up. We'll talk a little bit about baseball. I'll put the patch in place, and we're done. So it's
Awesome.
for it to be such a simplistic procedure. There's a lot involved as far as the harvesting portion of it, the testing requirements. Um, our particular amnion, we're kind of proud of it. We have our own proprietary way of preserving it, where we're not going to freeze dry this tissue and drop it really quickly, because we already know that if you drop it temperature too quickly, and then you're going to be losing all of those properties that are so precious, right? The proteins and the antibacterial and the lysozymes and the insulin-like growth factors, which is a whole other world of research that we everybody in the world is like, oh, we can use insulin on the cornea to help these damaged eyes. And we're over here going, hey guys, we've known that for 10 years. We can show you the articles. We've got that in the amnion. It's already present. Um, Man, it's just so it's more of an air dried system where the amnion has air flowing through it in a sterile environment. And we don't use any preservatives. So there's no alcohol base, there's no sulfa base. So you're not going to have any individuals that have any kind of drug allergies react to it. Uh, and then
Wow. So it truly is. It's totally minimally manipulated. It's really and truly
completely.
for,
Well,
yeah.
that's the point by the company from start to finish, is we want this to be a product that can be used and immediately show a result, it has a shelf life of 5 years, right?
Yeah.
So the tissue itself can be purchased in bulk or just use one, and the doctor doesn't have to use it that day. They don't have to use it in a special freezer. They don't have to keep it at a certain temperature. Just room temperature in its little folder case that is literally, you know, the size of
An envelope.
a
Yeah.
five by
Little
seven
tiny
envelope.
envelope.
Yeah.
Yeah. It's crazy. That's crazy. So tell me then a little bit, like getting from the elderly population into the student population. You just came back from Nova School of Optometry in Florida.
Yes.
And that's, I mean, obviously you're passionate about, treating all of our awesome people in nursing homes, but you're also passionate about teaching next generation ODs. Can you tell me how you kind of got into that, and what the experience is, and how these students are,
Oh,
as far as, just
it's
this.
exciting. It is. So it came to be where we were at a conference, and a whole group of students came through, and they asked, we were at a booth and we were willing to show them and educate them, and we sparked a conversation with a few of them, and lo and behold, one of them was a resident, and she and I just we kind of spent a few months talking back and forth, and she's like, this will be a great thing for you to come back and teach maybe some of the students or some of the other residents, because some of them could not come to this particular conference. And we reached out to the dean and to some of the other optometry schools and said, this is a thing. We like this. But I wanted to be more than just show up and teach a little bit of a section and then go home. So I wanted to form a relationship. I wanted to get to know the students, and where are you going to go practice, and can you use this in your practice if you're going to go join a partnership. Ask the doctors if they're using membranes in their practice, or if you're going to be offered a salary position but they don't do these extra services and procedures, can you use that to benefit yourself? Because you're going to come out of school and you're going to have student loans, you're going to have bills to pay. Be thinking from a business mindset of, how can this help me? So what we did is, my wife and I kind of got involved, and it was really a pretty cool blessing in disguise, where we do the resident workshop presentation, teach them about everything, and then we literally teach them how to apply the membranes on each other. And sometimes in clinic that day there might be a patient that has a rise that has a problem, so we can actually let them follow that through and treat that. But then we take them to dinner, and that's where you can see them let their guard down a little bit. And they had so many questions for my wife about life. And we're looking at joining this practice. And my husband's got this question. And my wife, wants to take a job here, and I want to try and do this modality. And so they wanted to ask her questions about, well, how was it when you guys were in school? How was it with taking care of the kids? And so it's just been a really
That's
cool,
wonderful.
multi-dimensional just relationship where they ask me questions, they ask her questions, and there's not one single thread of them being, embarrassed or anything, held against them,
Yeah.
because we're just there for them. So yeah, we're going on like 3 years now where we've added something this past year. So Nova, it was a big deal. We normally do the residents, which are the ones that have already graduated, but they're coming in from other optometry schools, and they're in, maybe a pediatric specialty or geriatric ocular disease specialty. And all of these different genres and specialties of optometry, and every single one of them, I'm able to show them that you are going to have a scenario, whether with a pediatric case with an abrasion from baseball practice, or ocular disease with some type of neurotrophic effect, or bandage contact lens with an ulcer. So all of them, you see the light bulbs go off and go, well, this is involving my type of practice. Maybe I need to look into this. So they came at us this year and said, we want you to not only get the residents that have already graduated, but we want to start the conversation and the dialogue of teaching them and getting them exposed in their second year. So they have this rotation where they have to learn all these specialty tests, right? Visual field machine for glaucoma, a B scan to look for things in the back of the eye, this procedure where they drain the tear ducts and all that stuff. And they said, could you come down for a week? And we have 130 students. We want, they're going to come through 30, 40 at a time for their rotation. And so I had a whole station to teach the second years before they go into full clinic, how to apply amniotic membranes, what to look for clinically. And so we're getting them at the beginning, and it's just a really cool process.
Awesome.
Yeah, and I have a business card that's more of an educational specialist card for ophthalmologics, and it has my cell phone number on it and my personal email, where I wanted these students to know, hey, email me, text me if you have issues. And I can't tell you, I had LinkedIn invitations. I had personal emails that were like, my wife and I are looking to move back to this state. Can you help me find someone? So it's really just been a network that I was not prepared for. I love it. I do. But I'm able to form relationships and help other practices and help these young clinicians, and now they're so comfortable. It's really cool. One of the residents, she's now one of the attending optometrists, and she had a case. She submitted a poster to one of the institutional reviews so she could go towards fellowship status. So they you can see their wheels are turning as you're leaving. They have questions, and it's pretty cool when a few of them are like, yeah, when I worked at this practice, we used membranes. I'm not sure which ones we used, but most of them are like, no, I've never seen that before. And they're on their phones reaching out to their doctors back home saying, hey, do you use this? I've never heard of this. And so it's spreading the word and getting it to the masses, if you will. So that's the goal, is everybody should know about this. That's the way I see it.
That's awesome. And you're also doing something crazy amazing with plasma pen and topical amnion, right?
Yes.
Yeah.
So we've got a plasma pen. So for the listeners out there, when I say plasma pen, it's the same energy as radio frequency. So if you go see these aesthetics commercials where facial aesthetics, where they're tightening and firming the tissue. So based on what the device's tip looks like, you can do it a very concise, almost like a needle point, which is what the Nuvista plasma pen does. So you can tighten and firm up the fine wrinkles around the eyes or that frontal brow region. The ladies refer to them as the 11 lines, right? They want to tighten those
Yes.
11s. I would say 11s, and then the crow's feet are the most
Mm.
popular requests. So what are you doing? That plasma energy is interacting. It's not interacting and cutting or touching the tissue. It is non-invasive, where an arc of plasma energy hits the tissue, and then the fibroblasts that are about 3 millimeters into that dermal junction, it stimulates them to grow tighter, firmer fibroblast collagen cells. That's
Wow.
that's the science behind it. The problem is that for a period of time, you're causing an insult of inflammation where there'll be a little red spots, right? And it takes a few days, and then we're wanting to let that fibroblast tighter tissue grow back firmer. Well, we have a company that Jim Novi that makes a product called Amnio Renew that is a serum that can be topically applied. So that's part of it. You say pre and post treatment, but it's kind of the magic in the serum that's helping introduce the all of those properties of the amnion, the anti-fibrotic, as far as scarring formation, the antibacterial, the anti-angiogenesis, where you want that tissue to grow back pure and healthy in a more fine line, finer, refined thing. The other thing we're finding is that the plasma energy, if you change the probe to a rounder tip, so instead of it being a needle tip, if it's more of a rounded base, then you can massage even the darker skin tones, right? Your Fitzpatrick skin types, 1, 2, 3 are optimal. But if you got a 4, 5, or 6 that's more of an olive or Latin American or African American skin type, then radio frequency, there's a risk of hyperpigmentation. So you switch the tip to a rounded tip, and instead of it being plasma, it's same device, but now it's called electrophoresis because
Okay.
you're delivering the energy in a more broader sweep. Well, we apply the Amnio Renew, and we're able to give these darker skin types that Meibomian gland therapy that they can't receive because IPL, which stands for intense pulsated light therapy, is contraindicated with darker skin types. It won't show the effect of using this bright flash of light to emit 120 degrees of a flash to help melt the blocked, backed up Meibomian oils. Well, if you can massage that and introduce the Amnio Renew serum to penetrate into that Meibomian area and cause the Meibomian inflammation around the glands to be less inflamed, to introduce healthier tissue, to introduce all of those proteins and particles that can help produce healthier, more stable Meibomian oils. That's part of that whole dry eye evaporative where the oils are not allowing it. So yes, the technology's there. We've been doing the studies. We are having amazing results where we can use the plasma to directly tighten the front surface of the eye in a condition called conjunctival chalasis, where that conjunctival tissue, for the listeners, it's that clear layer of tissue that sits on top of your eyeball that protects it from the elements of life. Well, sometimes that protective layer will release and cause a big bunch of folds over in the bottom corners. And
Wow.
then tears just kind of get all caught up in those folds. And so they need to be tightened up. So we'll use the needle plasma energy to just almost tack it down, if you will. And then we apply an amniotic membrane disc, an eclipse membrane, right onto that treatment area. So it ensures a healthier, tighter healing and a formation of tighter conjunctival tissue. So
Wow.
amnion is turning into, we've known that for years, where wound repair for gum disease, wound repair for podiatry, foot ulcers, things of that nature. That's been in place for years. But in the ophthalmic eye care world, man, we are making leaps and bounds as every day because we're helping the surface healing in a very short time frame. We're advancing these procedures with the plasma energy and coupling that with amnion. We're applying the aesthetics where these individuals that are doing the pre and post aesthetics are applying, instead of doing this expensive aftercare treatment plans, we're able to supply our patients with basically a unit bottle of the serum, and get the care they need. It's a very simple application. You don't have to store that in a certain temperature. You don't have to draw it from a vial and keep it in the freezer. It's a very simplified process. So, yeah, I've infused the amnion aspects into almost every aspect of my practice: nursing home, aesthetic optometry, ocular disease, primary care optometry. Every aspect of optometry can utilize amnion.
That is amazing. Well, we'll end it there, but
Yeah,
we're going to have you come back on because of all of the amazing things that you're doing. And I would love to see, where it's all going. I mean,
sure.
it's great. I
Yeah,
mean, you're going to be featured in the review of optometry in July. And I just you were just moving and shaking, and a
moving and
huge
shaking.
champion of amnion, which we absolutely love, and also obviously a very good steward of amnion. So we
Well,
just we appreciate, I appreciate your time, and I appreciate you being on our board as well. We are so fortunate and grateful to have you.
well, I appreciate it. I'm honored. Hey, if it's something that works and I can stand behind it, I don't have a problem, telling the world and educating everybody for sure.
I love it. I love it. Well, thank you guys for watching, and stay tuned for our next episode coming soon, and have a great day.